Okay, Assalamu alaikum everyone. Good evening. So this is Dr. Hira Salman. We are going to start our discussion. This is session number 1, and we have certain topics. So what we are going to do is first we will have a quick look of a topic. Say for example, we'll start with this congestive heart failure, and then we will solve some recent recalls based on this topic. So let's start with this congestive heart failure. I have already shared with you this MTB handouts. These are the exact handouts of MTB. Okay, Asha is here. So we have this new 5th edition with us. MTB handouts are unfortunately of the previous edition, but it's okay. Most of the things are the same. You are not going to find any difference in the handouts and the actual MTB. So we'll just start with this one. So I'm going to share my handouts with you. The first topic we are going to go quickly over is congestive heart failure. So there are certain names. You can say congestive heart failure, you can say chronic heart failure, means the same thing. So first of all, we just have a quick look. What is the presentation? If the because our main focus is recalls, right? So we are going to more focus on what will be the symptoms of the patient, the best initial, the most accurate test, what will be the best treatment for the patient. So we are going to emphasize more on these topics. So first, let's have a look. The symptoms of the patient, if he is or she is presenting with congestive heart failure, of course, shortness of breath will be there. That is difficulty in breathing, dyspnea will be there. That is the most important symptom. So whenever we are going to solve any question, we have to look for this finding, is if the patient is presenting with shortness of breath or not. That is the most indicator of this congestive heart failure. Second thing is that, of course, dysfunction of heart as a pump of blood. There will be difficulty in pumping of blood. So we have two things. The first thing is systole, when the heart contracts, and one thing is diastole, when the heart relaxes. So if there is difficulty in pumping, it means that the first thing, maybe there is difficulty in contraction, and the second thing, there is difficulty in relaxation. So we will divide our congestive heart failure. The causes we have to divide into two things: whether the dysfunction or difficulty is during the pumping, during the contraction, or during the relaxation. So based on that, we can say that maybe it's a systolic dysfunction. Whenever the heart wants to contract, there must be some difficulty during that state. So that is called the systolic dysfunction. Or maybe when the heart pumping is not accurate, maybe the reason, because when during dilatation, during relaxation, because we all know very well that when heart relaxes, it receives blood. So if there is a problem in relaxation, the heart is not going to receive blood. So again, we can say that there are two things. So maybe it's systolic dysfunction, maybe diastolic dysfunction, but there's a key role in between these two. And on the basis of these two features, we will say, okay, this is a systolic dysfunction and this is a diastolic dysfunction. And the main thing is ejection fraction. So whenever we are going to solve a recall based on congestive heart failure, we will think of this, okay, congestive heart failure is there, but whether it's a systolic dysfunction or diastolic dysfunction. So you always have to look for ejection fraction. Normal ejection fraction is 55 to 70%. So if in a question, if you see this ejection fraction is below 55, so you can think of always it's a systolic dysfunction, because in systolic dysfunction, there is always a low ejection fraction. The normal limit is 55 to 70. So if there is any question which says ejection fraction below 55%, it means that it's a systolic dysfunction. And if it's normal in between 55 to 70, we can say this ejection fraction is preserved, means it's a normal ejection fraction. So always think of diastolic dysfunction. Then later on, we will see what are the etiologies, what are the causative. Okay, getting this here. What are the actual reasons behind this? So first of all, we will have a just look of this most common causes of systolic dysfunction. So whenever there is a contraction difficulty, we will see hypertension resulting in cardiomyopathy. So increase in systolic blood pressure, increase in overall blood pressure. If we see, we can say maybe the patient who's having hypertension. So in a recall, there must be increased blood pressure. So first, we will look for any shortness of breath. Then we will look for this thing, hypertension. We will always go for the blood pressure finding. So blood pressure should be more than 120 by 80 in order to say it's a hypertensive patient. Initially, there is preservation of ejection fraction. Over time, the heart dilates, resulting in systolic dysfunction and low ejection fraction. So whenever we have to say that it's a systolic dysfunction, we will always see that, of course, blood pressure will be raised. And secondly, this ejection fraction. So it should be below 55. Because once you have a recall, once you have a question, you will always see it's below 55. Now, valvular heart disease of all types result in congestive heart failure. failure. So if the patient is already having any congenital valvular problem, you can say, oh, maybe this is etiology. This is a reason for this systolic dysfunction, congestive heart failure. Okay, now myocardial infarction is very, very important because two important things you are going to note here. The first thing is myocardial infarction is very common cause of dilated cardiomyopathy. So first of all, there is ischemia. There is low blood supply of heart. So when ischemia prolongs, we can say that there are the chances the heart is going to be infarcted. When the heart is going to be infarcted and it's actually infarcted, it's dilated. No more contraction you are going to see in the heart. And when, of course, there is dilatation, there will be chances of regurgitation, and that all leads to congestive heart failure. So there is a whole process. We cannot say that congestive heart failure causes MI. No, MI is the basic thing that leads to congestive heart failure. So this is a common mistake we usually do when we are solving MCQs. That first we have to remember that myocardial infarction is the basic thing that leads to congestive heart failure. Congestive heart failure is not the one who is going to cause myocardial infarction. That's a very important thing. So myocardial infarction is a very common cause of dilated cardiomyopathy. So dilated cardiomyopathy, you will see regurgitation with the passage of time, and that leads to congestive heart failure. Now, this is the most common cause of admission in USA. We are not going to deal with this one. This MI death rate down from, so thrombolytics, of course, these are all the things. Okay, so these are all the things we will get, and we will see what is actually going to decrease the mortality and what is actually going to decrease the symptoms. Again, I'm going to emphasize based on the MCQs, two things you must have to notice. The first thing is actually what are the drugs we are going to use to decrease the mortality of a patient. And second thing, what are the drugs we are going to use to decrease the symptoms of a patient. These are very, very important points, and we are going to discuss in detail. So we have these thrombolytics, we have beta blockers, angioplasty, we can go for aspirin, clopidogrel. These are all the things that are going to decrease the MI death rate down. So MI, so mortality and morbidity will be decreased because of the use of all these drugs. But which one is going to reduce the mortality and which one is going to reduce the symptoms, we will see later. Okay, so these are the less important causes. I'm not going to emphasize on this one. You can have a go with that, all this thing. Now quickly we will just go to this one. So the next thing which we are going to emphasize is what are the best initial tests and what are the most accurate tests and what is the best treatment and most important treatment. So here we will say that the best initial test is transthoracic echo. Must emphasize on this one, and most accurate test is multiple gate acquisition or nuclear ventrography. We are going to learn this by heart because no need to waste time on this one. Now, when should you answer, Nicola? This is again, this is very important. When should you answer BNP? Please make a note of it. This is very important, and it's a very common recall. They usually ask this question. Whenever you have a question with you which says you don't have facility, say for example, the patient presented to you with acute or severe shortness of breath in emergency department, and you don't have time even to go for echocardiography, what you will do? What you will do in order to diagnose, okay, quickly that maybe this patient is having congestive heart failure or no. What we are going to do, we will do this BNP levels. This especially this level if you are going to do, and the result will come in just in minutes. And if the results are normal, you can easily exclude that this patient is not a case of congestive heart failure. This is very important. So the presentation is same like congestive heart failure. You don't know any reason, you don't have time to go for echocardiography, you just quickly want to rule out congestive heart failure. You will check the level of this barium natriuretic peptide, and you will see if the levels are normal, you can easily exclude, okay, this is not a case of congestive heart failure. We have to evaluate for the pulmonary causes. So again, if you want to know the causes of congestive heart failure, so say for example, if you want to know, okay, MI was the reason for this for the presentation of congestive heart failure, you can go for the ECG. Of course, in ECG you will find changes and you will get to know, okay, maybe the patient has undergone myocardial infarction and that leads to congestive heart failure. Or if you want to rule out the patient is having any dilated cardiomyopathy, you will go for the chest X-ray. If you want to see, okay, maybe the cause was arrhythmia, you will have to attach Holter monitor. But Holter monitor is not going to give you result in minutes or in hours, no, or in a day even. So it has to take at least 24 hours to monitor, especially this Holter monitoring. Holter monitoring requires 24 hours monitoring. But that's a very important thing. It can easily rule out arrhythmia. So you can say, okay, arrhythmia was the reason. That's why the patient is presenting with congestive heart failure. Then If the patient is having any septal defects, we can go for cardiac catheterization. So these are actually the tests which used to determine what is the reason behind congestive heart failure. Or if the patient is only having anemia and that leads to congestive heart failure because of anemia, because of the ischemia, because of the infarction, you can always go for CBC checking. So hemoglobin will especially rule out. Hypothyroid, both these patients can present with congestive heart failure. So you can see both high and low levels of thyroid. Similarly, if you want to exclude sarcoid, amyloid, really needed can biopsy at the site, we can go for myocardial biopsy, but that's a very rare thing. So just leave all this. Only the important things are this one. For MI, you can go for ECG, for dilated cardiomyopathy, chest X-ray, and this anemia CBC. Usually, we are only considering these three in normal routine clinical practice. Now, what you're going to go for the treatment, if there's a systolic dysfunction, always remember how you're going to differentiate that this patient is having low ejection, this patient is having systolic dysfunction, this patient is having diastolic dysfunction. You will always go to check for this one, ejection fraction. So if ejection fraction is below 55, you will say it's a systolic dysfunction, and the ejection fraction is preserved, normal, you are not going to see any changes in this, you will say, okay, it's a diastolic dysfunction. So here we have the most and foremost important is ACE inhibitor, angiotensin converting enzyme inhibitors. We have beta blockers, we have spironolactone, but spironolactone here is not acting as a diuretic. You will see this later. And then we have diuretics and digoxin. So this ACE and ARBs, these are the most important. So anything ending with the ill, like captopril, enalapril, lisinopril, fosinopril. So anything ending with ill, you will say it's a ACE inhibitor, it's the angiotensin converting enzyme inhibitors, and that is the most important drug which is going to reduce the mortality in your patient. That's very important. It's not going to improve the symptoms of a patient, like acute symptoms. If you want to relieve, maybe you're not going to have any benefit for relieving the symptoms, but in terms of mortality, like with the passage of time, if you give this ACE inhibitor, definitely that's going to decrease the mortality in the patient. Then you can give in all stages of disease beneficial effects. We will see this one. So when we are going to give ARBs, angiotensin, this one, especially ARBs, only when the ACEs are going to show the productive cough, which is very less common in about 7% of patients, they are usually present with this productive cough. We can say, okay, you can switch ACE to ARBs, but both are having the same effects, no changes. Only when there is too much cough, which is only happening in 7% of patients, but when it happens, it's very aggressive cough. So we will just change this ACE inhibitors to ARBs. Beta blockers, we have all this ending with all. These are going to reduce the mortality, but first and foremost, ACE inhibitors, and then comes beta blocker. This spironolactone, this is important because this spironolactone we are not going to give again for the symptomatic treatment because it's not working as a diuretic here. What is actually working here? It's benefit from inhibition of aldosterone, only proven for more advanced congestive heart failure with this on minimal exertion at rest. So this is very advanced drug. This is only going to produce effects when there is advanced congestive heart failure. So what is going to do, and what are the most common adverse effect of this one? This is hypokalemia, gynecomastia, it's okay. But just one most important point here, just remember this one, that spironolactone is not going to be a diuretic here. It's going to, of course, decrease the mortality, but in very advanced disease. When you are going to give aplerenone, when gynecomastia is severe, you can just switch this to aplerenone because it has no effects on, and it has no any anti-androgenic effects. Now, this is very important, diuretics. Very important point here is diuretics control the symptoms of congestive heart failure. So if the patient is presenting with acute shortness of breath and you want to relieve the symptom of your patient, first and foremost treatment will be furosemide. You are going to give diuretics to that patient, not spironolactone, right? Furosemide, the first diuretic you are going to give to your patient. This is going to decrease the symptoms in your patient, not the mortality. For mortality, always consider ACE inhibitors. Always enalapril. Enalapril is the best choice of drug. So here, so it's mentioned clearly in emergency department, if the patient comes to you with this acute pulmonary edema, acute severe shortness of breath, you will always consider diuretics. But in office, say for example in OPD, if the patient presents, so in OPD you can always prescribe this ACE inhibitors or ARBs. So furosemide is the first choice. Then again we have all this, and spironolactone, although a diuretic, but it's not used as a dose where it has a diuretic effect. we are going to give it in late advanced stage of disease, say for example in 3 or 4 stages. So this is an important point. Diuretic control symptoms of congestive heart failure, they do not lower mortality. Only ACE inhibitors, and especially enalapril, is going to reduce the mortality in the patient. Then we have this digoxin. Digoxin does not lower mortality. So when we are going to give digoxin, when we want to control symptoms, we want to decrease frequency of hospitalization. So for the stabilization of a patient, you can give, because it's an inotropic agent. And these are the devices with mortality benefit. So if they are okay, now again here important thing. So if you have, say for example, if you have ACE inhibitors also in the answer choices, and if you have this implantable defibrillators also in the answer choices, never go for the defibrillator first attempt. You have to go for the medication first. If the question says advanced and you don't have any option, or what is the long-term planning, so for the long-term planning, we can choose implantable defibrillator. This is the one recall where it has both the things, ACE inhibitors plus implantable defibrillator, and they are actually asked that for the long-term management, what will be the best suited option. So of course, for the long-term management, we will go for this implantable defibrillator. But if they're asking just to reduce the mortality, always choose ACE inhibitors. Okay. Then this biventricular pacemaker is not a dual chamber. These pacemaker, again, we have this one mentioned above here, biventricular pacemaker. We have two choices, implantable defibrillator and pacemaker. But defibrillator, among these two, we will always prefer defibrillators. Then transplantation symptom, despite maximal medical therapy, the patient is on full maximal therapy and he's already having this biventricular pacemaker, no improvement in patient, then of course we'll go for the transplantation. Okay, so we are done with this one. So just have a look on this one. We'll go to the question sides. Okay, so here I want your interaction. The first question, which of the following agents has been shown? These are actual recalls, but I need to paraphrase them in order to have in order to make sense of a question, especially. So the first is, which of the following agents has been shown to reduce symptoms in patients with congestive heart failure? Please make a note of it. There are two important recalls here. The first one always says reduce symptoms, and the second one reduce mortality. So I've already emphasized a lot during this theory. So can anyone tell me the answer?
It's furosemide.
Furosemide, exactly. So whenever it says symptoms, always think of diuretics. And in diuretics, first and foremost will be furosemide. If there is no name of medication, of course, you will choose diuretic. But if there is any name of medication, like here furosemide is mentioned or torsemide, but in between two, always go for the furosemide. So here the correct answer is furosemide. Okay. Second question, which of the following agents has been shown to reduce mortality in patients? Same question. I didn't make any changes because I don't know the answer choices as well. Only 2 or 3. But mention mortality, reduce mortality. So we will go for enalapril. Exactly, because this is the ACE inhibitor. So if ACE inhibitor is mentioned or enalapril is mentioned, go for this one. Enalapril is the most important one because in routine clinical practice, we are also going to give this enalapril as compared to gabapentin. Now, what is the best initial test for congestive heart failure? Again, we did this one. Anyone?
Transthoracic echo.
Transthoracic echo.
Enalapril is which group?
It's ACE inhibitors, angiotensin converting enzyme inhibitors. So always remember, whenever the word mortality is there, always think of enalapril. And whenever the word reduces symptoms, always think of furosemide, because diuretic is for reducing symptoms and enalapril, which is an ACE inhibitor, is for reducing mortality. These two important recalls. Maybe the answer choices are different. You are not going to see these answer choices, but these words are the same: reduce symptoms and reduce mortality. So make a note of it, okay? Now, when we are going to check ECG, if we are suspecting MI as a cause, but here it's just asking for best initial test, straightforward, and MCQ straightforward answer. Which of the following tests exclude congestive heart failure? Remember, when you don't have time to go for echo, what you will do? BNP. So if normal BNP, it means that congestive heart failure is excluded. You are going to exclude congestive heart failure. Okay. Now for the next one, we have to go for digoxin toxicity. Okay, page number 79. Digoxin toxicity. So, very important recall for digoxin toxicity. There are 3-4 very important recalls. They keep on repeating the same questions, but the context is different. Which is going to predispose to digoxin toxicity? And once digoxin toxicity is established, it can cause what? So these 2 important points, please make a note of it. The first thing, who is going to predispose to digoxin toxicity? And once the digoxin toxicity is established, what you are going to see in your patient. So this is important. Hypokalemia predisposes to digoxin toxicity. Why? Because digoxin and potassium, both of them have to go for one same receptor. Potassium also go to the same receptor, and digoxin will also go to that same receptor. So what we have, if we have digoxin, if we have hypokalemia, like I have less amount of potassium in my blood, what will be the result? If no doubt, if there is normal amount of digoxin, but because of the low level of potassium, more and more digoxin is going to bind to that receptor. And what will happen? There will be toxicity of the digoxin because there will be too much level of the digoxin. Although the patient is having the same intake of digoxin, but because of hypokalemia, what will happen? There will be no potassium to bind with that receptor, and digoxin will have more chance to bind to the receptor. So in order to binding of the receptor, more and more digoxin will go, and there will be toxic level of digoxin. And once there will be too much digoxin binding to the receptor, what will happen? The potassium will not get any chance. And when the potassium will not get any chance, there will be too much level of potassium in the blood, and that leads to hyperkalemia. So these 2 important recalls. The first one is, before digoxin toxicity, if the patient is having hypokalemia because of any reason, hypokalemia is there, that leads to digoxin toxicity. Although the patient is taking normal level of digoxin, that's an inotropic agent, we use this as for antiarrhythmic, but the patient is taking normal amount. But what happens? Why the patient is actually presenting with toxicity? Because maybe because of any reason the patient is having hypokalemia, and that leads to digoxin toxicity. And once digoxin toxicity is established, what will happen? You will see later on the hyperkalemia, because more and more digoxin will be there, and the potassium is not going to get any chance to bind with the receptor, although the levels are there, but no chance for the receptor. More and more potassium will be in the blood, and that can lead to hyperkalemia. So hypokalemia predisposes to digoxin because potassium and digoxin compete for the same site, this receptor, sodium potassium ATPase receptor. So less potassium is bound. Of course, if there is less potassium, the more digoxin will get a chance to bind. So what happened? So the 1 or 2 recalls are based on this thing. The second is the presentation. You are going to see the patient is presenting with this symptoms. What will be the toxicity? Straightforward recall. So we have to just look for the thing. Mostly the patients are presenting with confusion. They are having high potassium in the blood. They are having nausea, vomiting, abdominal pain. Of course, because of the potassium, increased level of potassium, you will see arrhythmias. And again, this is very important to see in the recall. In your question, the patient will say, of course, straightforward, it will not be mentioned like this, yellow halo vision. No, the patient will say to you that, doctor, I'm seeing everything in yellow. Like there is yellow border to everything. If I'm seeing this cupboard, there is a yellow margin on that cupboard. If I'm seeing this fan, there is a yellow margin on that fan. So the patient is going to say that I'm going to see everything in yellow. So it means that, and in history, of course, when you inquire, the patient must be having a previous history of arrhythmia, having history of digoxin intake. So it's a very clear clue for you that it may be a digoxin toxicity. So what you will do, you will check the digoxin level. That's the most accurate test. And the best initial test is potassium level. Of course, it will show you hyperkalemia, and you will see ECG. So ECG is downsloping of ST segment in all leads. You will see. And again, the third recall, which is very common for digoxin. That's why I chose this topic, because again, you can see in the ECG, they usually ask this one, that mostly the patient who are having atrial tachycardia with variable AV block, which toxicity you're going to see in the patient. So which toxic levels are there in the patient which can cause atrial tachycardia. So this is digoxin, because digoxin is an inotropic agent. So you will see atrial tachycardia. Inotropic means they are going to increase the force of contraction of the heart. That will result in atrial tachycardia. And especially which type of arrhythmia, which type of block, it's a variable AV block. You can see changes in the QRS complex. So atrial tachycardia, with AV block, always remember, if you've seen an ECG, always inquire about the digoxin, and you will see digoxin toxicity in that patient. Maybe it's in the started or initial phases, but later on, if there will be evidence, yeah, the patient is having digoxin toxicity.
Dr. Hira, I have one question here.
Yeah.
Atrial tachycardia is caused by SA nodal complication. Am I right or okay?
Yeah, but that is only the one cause.
Okay.
That is only the one cause. There are lots of causes for this one. Yeah. So if the patient is having any chronotropic agent, if the patient is on a positive chronotropic agent or positive inotropic agent, that can also lead to tachycardia, because tachycardia means increased heart rate. So there may be a nodal dysfunction, there may be any agent who is taking outside, like these inotropic agents or chronotropic agents, they are going to increase heart rate. So you will see increased heart rate. And atria actually contributing heart rate, but it's not very much compatible to ventricle, right? So ventricle are the one which are actually making the heart rate of a patient, not the atria. But again, atria is important, right? Because when atria contracts,
my question was that the digoxin is anyhow acting over the SA node.
Yes, yeah. The site is SA node, exactly. So in any ways, the pathophysiology will remain the same. Exactly. True.
Okay.
All right. So now let's see the question. I think there is nothing more significant here. So let's go to the question. So here the question says a 40-year-old woman presents to the emergency department with vomiting and generalized abdominal pain. So we'll look for the age of the patient, where the patient is presenting to the emergency department, what are the symptoms, vomiting, generalized abdominal pain. She does not know her medications. Here's the problem. She is taking medication, but which medication she doesn't know. She states that her vision has been slightly yellow tinged recently. Blood pressure is 90/50, heart rate is 60, respiratory rate 16, temperature is 37. Which of the following is the most likely diagnosis? What you're going to see, or what you're going to suspect in this patient? So see here, the most important clues will be vomiting and abdominal pain. That's a most important presentation. But these presentation are vague, because you can see vomiting and abdominal pain in many of the other conditions. But here the third clue, which says vision has been slightly yellow tinged recently, and especially these, if you can see, there's blood pressure findings and heart rate decreases. So these are the four things which will make the diagnosis clear that this is a case of digoxin toxicity. Okay. Now the another one, which of the following condition predisposes to digoxin toxicity? The word predisposes, please remember, predisposes, not leads to. Digoxin toxicity leads to, that is the separate thing, and predisposes to digoxin toxicity. So which of the following will predispose to? Hypokalemia, of course. Whenever there is less potassium, then digoxin will get more chance to bind with sodium potassium ATPase receptor. Exactly. And atrial tachycardia with variable AV block is most commonly seen in, that's the same thing, atrial tachycardia. So with variable AV block. So in which of the following poisoning? So again, this is very clear. Digoxin toxicity. These three are very important, because now this one, digoxin toxicity can result in.
Please, doctor, please explain question number 7.
7 is atrial tachycardia with variable AV block. You remember this one? Where it is, I will just show you here. This one. This important thing, like atrial tachycardia with variable AV block is the most common digoxin toxic arrhythmia. The arrhythmia that is actually caused by digoxin toxicity. Whenever there is too much digoxin, too much inotropic agent, that will lead to atrial tachycardia. So here they are just saying you in the question. It's a reverse question actually.
Okay. Yeah. Digoxin is positive inotropic to give
positive inotropic. Yes, that will
positive inotropic. It is given to reduce the heart rate. So there will be AV block.
Okay. Yes, there will be AV block. And which type of AV block? That's a variable AV block. So it's a clear-cut question, and it usually comes like this. Yes. Now digoxin toxicity can result in, so leads to, so whenever there is too much digoxin, potassium will not going to get a chance to bind. So there will be more level of potassium. Okay. Next one we have to go for another topic. Bacterial endocarditis 202. We'll go to 202. we have this endocarditis. For endocarditis question, you are going to get maybe multiple questions. You are going to see multiple questions of this endocarditis where they are asking. The prophylaxis questions are very common. They will give you a scenario that the patient is going to go for the dental extraction. Are you going to give endocarditis prophylaxis? What should be the dose for this endocarditis prophylaxis, augmentin dose or ampicillin dose? These questions are very, very common. Similarly, they're going to give you a scenario where they say the patient is going to have some kidney problem and he's going to go for stenting. Are you going to give this endocarditis prophylaxis? So this prophylaxis question is very, very, very important. So there are certain parameters which we have to understand and learn by heart, that in these patients, we are going to give endocarditis prophylaxis. Prophylaxis question is very important. And presentation. So whenever the word says fever and murmur, always think of endocarditis. So any question which says the patient is presenting with fever and a murmur. So murmur and a fever and a murmur, always think of endocarditis. So here it's a heart valve infection. Fever and murmur, two very most important findings you will see definitely in the question. Diagnosis, you have to go for positive blood cultures. We will see this culture because there's infection of the heart muscles. So of course, we'll go for the blood cultures and we will see whether there is a bacterial or which type of infective endocarditis is this one. Rare on normal heart valve, except if we have any intrauterine devices, and risk proportional to degree of damage of valves and regurgitant and stenotic lesions have increased risk. So very, very important thing again is there, the patient must be having any previous history of heart valve replacement. There must be any prosthetic valve inside. And that prosthetic valve is actually damages the heart and there's infection in that prosthetic valve. We will always think of this endocarditis. So not actually in the normal heart valve, normal heart functioning valve, but always if there is any problem in the heart valve or if there is any prosthetic valve inside, means artificial valve inside, those are actually are more prone towards infection. But of course, in normal valve can occur if there is septicemia, if there is any bacterial infection, say for example, in the case of severe bacteremia, that bacteremia will of course involve the normal heart valves, and that heart valves can show endocarditis. Highly pathogenic organism. Which organism is this one? So bacterial Staphylococcus aureus, we have to remember this one. So if there is any history of this infection or any history of infection that is caused by staph, so that is again very important. Say for example, Staphylococcus aureus is also very, very common in pharyngitis, right? So look for any previous history. Maybe the patient is having any previous history of throat infection, or it's mentioned only throat infection. Pharyngitis is not there. Or maybe any clue which is pointing towards pharyngitis. You can think of, okay, the patient was having pharyngitis and after 10 days, the patient is going to present with fever and the murmur. So you can always correlate because Staph aureus is the most common organism for this infection. So what Staph can also cause in other parts of the body. So maybe that infection can lead to this endocarditis. So in a history, you can always you have to check whether the patient is having any prosthetic valve. On history, you will check if there is any history of any dental work extraction, because this dental activity is the way where most commonly the bacteria has a chance to go over, because there are a lot of blood contamination will be there. So always in the question you will look for history of any dental extraction. Maybe the patient has undergone a dental extraction 10, 15, 20 days back, or the patient was having sore throat 10 to 15 days back, and then he suddenly developed fever and a murmur. So always correlate with the history. So dental procedures with blood confer a small risk of endocarditis, but there is a small risk, but there is always a risk. Surgery of mouth and respiratory tract confers no risk unless severe valve disease is present. Artificial valve or cyanotic heart disease. So artificial valve, prosthetic valves are more prone towards getting infection easily, or else if the patient is having severe bacteremia, that can lead to endocarditis. Okay. Endoscopy confers no risk even with biopsy. So if there is any clue in the history which says endoscopy, we will not bother that one, because endoscopy confers no risk even with biopsy. Also, we don't have any risk. We have risk if there is any dental procedure. We have risk if the patient is having any bacteremia before 20-15 days back. If the patient is having any surgery of the mouth or any surgery of any respiratory tract infection before, so we'll always think of this. Now, what is the most likely diagnosis? Now, again, the presentation, you will have clues in the history, you will have clues in the MCQ that maybe the patient, fever and murmur, of course, these two are very, very important. So always patient is having fever, murmur, no ambiguity in this one. Then complications, again, we will see splinter hemorrhages. So we will solve one report, we will see that the patient presents with splinter hemorrhages. There are flat and painless lesions. Osseous nodes, we are going to see the small raised and painful osseous nodes with soft tissue swelling. There are some blood spots in the eyes. They're also going to give you a clue. Brain, myocardial aneurysm, kidney. These are all the advanced, but you can see hematuria. The patient may also present with hematuria. These are actually the presentation. So the patient is having fever, the patient is having murmur, the patient is also complaining of hematuria, like blood in urine, or the patient is having history of glomerulonephritis. Always think of this endocarditis. This conjunctival petechial rashes, splenomegaly, septic embolism, lungs. So these are all the possible things that can be there if the patient is having endocarditis. It means we have to choose endocarditis if the patient is having all these things or any of them. So what we are going to do, best initial test, we will go always for blood culture because we have to rule out which bacteria is there. So 95 to 99%. If positive, do an echo. So whenever blood culture is positive, we'll go for echocardiography. And echocardiography, we have transthoracic echo, we have transesophageal echo. But remember, in this case, transesophageal echo have high sensitivity and specificity because this is more likely we are going to have this one. But in transesophageal echo, we usually prefer in obese patients. We usually go for transthoracic echo. ECG rarely shows AV block if dissection of conduction system occurs. If there is any, then we can go for ECG. Otherwise, ECG is not going to give you any proper clue. But always remember, whenever there is fever, murmur, any history of infection, any history of dental work prior, always think of this fever. And the presentation will be splinter hemorrhage. Most importantly, if the patient is having conjunctival petechial rashes, if the patient is having osseous nodes, there's infection of the soft tissue of the fingers, or maybe there is on palpation, you can find splenomegaly. Always think of this endocarditis. Let's have a quick question of this one. So these are all the treatment regime, what we are going to give. So of course, treatment will depend on what you're going to give in blood, what you're going to receive in blood cultures. So say, for example, in blood culture, you have this Viridins infection, you will go for ceftriaxone. So what we will do, always when we perform blood cultures, we have to start any antibiotic, that is empiric antibiotic, prior to this blood culture, and then later on we have to change as per the blood culture result. Like say, for example, today I have ordered this blood culture for my patient, and today I'm going to start medication. I will instruct my patient that first you will go and give your blood sample, and then you will take this medicine, and that should be the empiric antibiotic. But later on, when you have result with you, what you will do, you will just change this empiric to the particular one. The result shows sensitivity to that drug, that is okay, you're not going to change. But if there is resistance, of course, you're going to change it to any other antibiotic. So the point is, you should know what is the empiric antibiotic, and whenever you have definite test in your hand, definite bacteria in your hand, okay, this is the bacteria, you are going to change the medication. So for Viridins, ceftriaxone. For Staphylococcus aureus, we have to give this oxacillin, nephicillin. Fungal infection, you can give amphotericin, vancomycin. So always the best option is for empiric therapy. We can always offer ceftriaxone. Later on, we can change as per the patients who is having which bacteria. So treatment of resistant organisms, say for example, those who are resistant to everything, we have to add aminoglycoside. When is surgery the answer? When we are going to go for the surgery, if there is congestive heart failure, ruptured valve, prosthetic valve, fungal endocarditis, because fungus are mostly resistant to every antibiotic. We don't have any option because medicine is not going to work, antibiotic is not going to work. Or abscess, AV block is there, recurrent emboli while on antibiotics. So these are certain conditions in which we will go for surgery. But mostly endocarditis is curable on antibiotics, on medical treatment. So we will add rifampin for prosthetic valve endocarditis if there is an artificial valve inside the patient and that valve is actually infected. We can add rifampin as well. The single strongest indication of surgery is acute valve rupture. So this is again important. What is going to go for the absolute indication of surgery? Especially, you can always say, okay, whenever there is rupture of the valve, we don't have any option. We straight away go for the surgery. Okay, so again, you are going to just memorize this one. There is nothing like this one is very important for our MCQ point of view. Prophylaxis.
Excuse me, doctor. Please
Yes,
read
yes.
the above point.
Which point, doctor?
Up.
Okay, this one.
The left side. Treatment for resistant organisms.
Treatment for resistant organisms means that, like, we have found fungal infection, right? The cause is not bacteria, the cause is fungus. Mostly the fungal infections, they are not going to respond to an antibiotic. What we have to do, like, the last resort is we have to go for surgery. And some bacteria also, they are very resistant. They are not going to work. Even we have added aminoglycosides. Aminoglycosides are usually for the resistant bacteria, like those bacteria which are not which have resistant strains. They are not going to be killed with. Yeah. Yes. That's an alternative. You can go for that one also, erythromycin. But the point is, you just remember this one. When you don't have any option, you will go for surgery, because in case of, and not only you don't have option, when you have abscess, when you have prosthetic valve infection, when you have when the patient is having recurrent emboli, there are certain conditions. But honestly, MCQs, they are not usually asking these type of questions. They usually ask, like, if the patient is, what is the empiric antibiotic? The normal question is they're asking you for the empiric antibiotic. So you must know the empiric one. Empiric one means that is you're going to give to every patient. Later on, you will change. Yeah. And this one also, especially those who are having this resistance. So just remember, for resistant, those are presenting with resistant to antibiotic, you will give aminoglycosides. Just remember aminoglycosides. For surgery indication, the absolute indication is the one when the valve is ruptured. You have no choice. Go for surgery. Okay. So now again, for your MCQ point of view, please go for this prophylaxis for endocarditis. Lots of recalls are there. I will check the last year recalls, because I'm just doing this recent recalls which I've shared on the group. Especially, I think the 10 or 12 recalls papers are there, 40-50 questions each. So in that, I don't have much about this one, but previously, if you could go for the last 2019-2018 recalls, you will find lots of questions for this prophylaxis for endocarditis. They usually give scenarios like this one. The patient is going to go for dental surgery. Are you going to give prophylaxis? You have to choose yes. So these are all the listed things here when you are going to give and when you are not going to give. You have to memorize, you have to learn by heart. There is no choice. Amoxicillin prior to procedure. So you have to give 2 gram amoxicillin 1 hour before surgery. Always remember this one. This is also important recall. I didn't find this recall in during this year, so I won't be able to jot it down. But you have to memorize the dose, especially 2 gram IV 1 hour before surgery. That is the fixed dose for prophylaxis. If penicillin allergic, we will go for clindamycin, or we can go for azithromycin, clarithromycin. That is very rare, but of course we have to ask penicillin allergy. So just memorize this one. If the patient is allergic to penicillin, you can give clindamycin. Procedures and anatomic abnormalities that do not need prophylaxis are. So now this is again very important when you are not going to give prophylaxis. So whenever, if you are offering endoscopy to any patient, or if there any obs and gynae procedure, you are going for laparotomy or laparoscopy or hysterectomy, no need to give this one. No need to give endocarditis prophylaxis. Are you going to go for any urological procedure? No need to give endocarditis prophylaxis. Even the patient is having MV prolapse, even with murmur, no need. Mitral regurgitation, mitral stenosis, aortic regurgitation, all these valvular heart diseases, no need. Cardiomyopathy, atrial septal defect, no need. When there is a need, whenever there is a dental extraction, you remember the causes. So the causes are the one where you have to give, and the most important causes are especially dental procedures. Especially if the patient is having any surgery of the mouth, you have to give. These are the two important ones. And what is the dose, empiric dose of ampicillin? That is 2 gram IV 1 hour before surgery. Very important. Okay, so let's go for the question. I don't have questions over these, but I emphasize on these things because these are the very important recalls. So we'll go for the questions. Okay, so here the question says, a 39-year-old man presents to the clinic with unexplained fever. So we'll look for the age of the patient. Always, whenever you are solving a recall, always look for the age of the patient, the presentation, like he is presenting to the clinic. 39 years old. Unexplained fever for 19 days after an attack of acute rheumatic fever. See, So you have to make points in your head that rheumatic fever was there. 19 days fever is there. He was having a history of this fever, and he's presenting to the clinic. The age of the patient is this one. Sex also matters sometimes. Several of his teeth have been extracted prior to the hospital admission. So there's a history of too much work done on his teeth. Clinical examination confirms the systolic murmur. So fever and a murmur, murmur and a fever. No need to think. Always go for endocarditis. And splenomegaly is there. Remember, on palpation you will find splenomegaly. So there are lots of things here which are pointing towards, which are saying that this is a case of endocarditis. As per the fever, as per the murmur, dental history, teeth extraction history, fever history especially is there, septicemia, and splenomegaly. So these are all the findings. So we'll see WBC count, of course, it will be raised, neutrophils raised. So whenever neutrophils raised, always think of bacterial infection. Whenever lymphocytes raised, always think of viral infection. So neutrophils raised, of course, bacterial infection is there. And you will see this one, which of the following is the hematuria. Hematuria. Remember, hematuria also is one of the important clue for endocarditis. So which of the following is the most likely diagnosis? So we'll straight away go for
Endocarditis.
bacterial endocarditis. Exactly. Why we are saying bacterial? They can also mention infective endocarditis. They can also mention endocarditis only. But why bacterial? Because here there is a clear-cut clue, and when we will go for the cultures, we will have a definite result. But WBC raised, neutrophil raised, there is no point of saying that there is no bacterial infection. Of course, there is bacterial infection. No point of fungal here. And rheumatic fever, of course, again in the clue. Okay, this one. Okay, a 30-year-old intravenous drug user. He is actually playing with the blood, right? IV drug user, 30 years old. Fever, night sweats, chest pain, and arthralgia. On examination, painless erythematous lesions noted on the palms of the hand, with round erythematous lesion and central clearing noted in the retina, splinter hemorrhages under the fingernails. So he's presenting with the minor criteria. Say, for example, fingernails, splinter hemorrhages are there. These erythematous lesions are there. So splinter hemorrhage again is important clue for you. Fever is there, but here you're not saying any murmur here, right? It's not mentioned here, but of course we have other clues here in the question. So if you just go for again quickly, we have just looked this one, other findings. See, so it's not mandatory that you have fever and murmur. Of course, fever and murmur will be endocarditis. But again, if you find these splinter hemorrhages, if you find osteonodes, all the conjunctival pedicle rashes, splenomegaly, septic emboli to the lung. So remember these points also, because they are pointing towards the diagnosis of clinic this bacterial endocarditis. So where is our question? Question says IV drug abuser, fever, night sweats, chest pain, arthralgia, hand lesions, central clearing, this one, splinter hemorrhages, so especially under the nails. So which of the following is the most likely diagnosis? So you can rule out the other infections as well, but mostly you will go for bacterial endocarditis.
IV drug abuse.
That also give you a big clue.
Yes. Is a clue.
Yeah, that clue also. This splinter hemorrhages also, and of course fever. There is no murmur, but chest pain is there. We can, of course, on auscultation, maybe there is there because it's a recall. It's not mentioned here. Maybe it's there on auscultation. But I have asked exclusively. The doctor said no, there was nothing related to murmur. But anyhow, okay. Then we have to go for another topic. So this one, unstable angina. So for unstable angina, we will go for ambus. And just let me know if you can see ambus also. Can you see the ambus screen?
Yes, doctor.
Okay. So it's a very big topic. We cannot cover the whole topic now. We will just only focus on unstable angina. So the topic is actually acute coronary syndrome. And this acute coronary syndrome, we are going to divide this acute coronary syndrome into two main things. One, acute coronary syndrome in which there is non-ST elevation, and one which is having ST elevation. Only these two. Non-ST elevation ACS and ST elevation ACS. And then in non-ST elevation ACS, we have two things. Again, that is, one is unstable angina and one is non-ST elevation MI. So when the word MI comes, always think of it's a subcategory. It's a subcategory of ACS. Which subcategory? Either it belongs to non-ST elevation MI or it belongs to ST elevation acute coronary syndrome. So in ST elevation acute coronary syndrome, we have only one category, and that is ST elevation MI. So two categories. One is non-ST elevation acute coronary syndrome, and one is ST elevation, that where you will see elevation in the ST segment, that is ST elevation acute coronary. And in ST elevation, of course, there is ST elevation, so there is, we will say this is ST elevation MI. But in case of non-ST elevation acute coronary syndrome, we have one thing, that is unstable angina, and one thing where we have MI, but there is no ST elevation. So we are just going to consider here for the unstable angina, because this is acute myocardial ischemia. There is low blood supply, lack of blood supply to the heart, that is not severe enough to cause detectable quantities of myocardial injury. There is myocardial injury because you are giving less supply to the heart. Heart is receiving very less amount of blood, and with the passage of time, what will happen? There will be ischemia, there will be infarction, there will be dilatation, there will be regurgitation, there will be congestive heart failure. So there is a series of events that can occur in heart, but it started very, in the very initial state. There is ischemia, but that ischemia is not that much enough that can lead to very obvious change in the heart. So acute myocardial ischemia, that is not severe, that is not severe enough to cause detectable quantities of myocardial injury. What are the things that can give you a clue that there is injury? The biomarkers. Yes, so the biomarkers will not be raised in case of unstable angina. So biomarkers or ST segment elevation, of course, there will be no changes in the ECG because it's not significant enough. Damage is there, like lack of blood supply is there, but it's not that much that is going to change the ECG or that is going to increase the biomarker levels. No, you're not going to see. Now, symptoms are not reproducible or predictable. Sometimes patient can say, oh, I was just sitting on a sofa and I was having this chest pain. So angina at rest also with minimal exertion, or the patient may say, I was just walking down the street, not up the street, and I was having this chest pain. Usually not relieved by rest or nitroglycerin. This is the pain which is not going to relieve by the medication. New onset angina, first time occurs. Severe, persistent or worsening angina can be there, and autonomic symptoms may be present. Say, for example, there will be diaphoresis, that is excessive sweating. There will be syncope. There will be palpitation. The patient can say, I was having nausea, vomiting, and there was a chest pain while I was sitting on the sofa. So you can always think of this unstable angina. And the important clue is that what you are going to do, you are going to check cardiac troponin. This important thing. So cardiac troponin, there will be no elevation because biomarkers will not be changed if it's a case of unstable angina. You will check the ECG. There will be no change in the ECG. Or might be there's a slight change in ECG, but after some time when you repeat the ECG, there will be perfect ECG. So again, there is a clue for you, because I remember, and I will show you the recall also, the one important question which says that the patient shows some ECG changes, but after some time, there was a perfect ECG. So in that case also, you will always think of this unstable angina. And of course, when you go for the trop levels, you will see the normal trop level. There will be no changes on the ECG most of the time. Pathophysiology is partial occlusion of coronary vessel that can lead to blood supply, decreased blood supply. And of course, whenever there is decreased blood supply, there will be ischemia. But ischemia is reversible. Once it goes to infarction, infarction is irreversible. Of course, infarction will always lead to a dilatation, and dilatation again lead to regurgitation, and that leads to congestive heart failure. So that's a whole theory. Now we will see the treatment. Treatment, invasive management depends on risk stratification. For example, we'll go for the STEMI scoring. We'll check this scoring later. Anticoagulant, antiplatelet therapy, that's the most important thing we have to give always to reduce mortality of a patient. Aspirin, that's the most important thing. As statins, we are going to give. Antihypertensive therapy, we are going to give beta blocker in control, and ACIs, they will always reduce the mortality of a patient. Pain management. So these are the things. So the most important thing which you're going to memorize here, always in your recall, in your MCQ, the patient will say something like that. The pain started while during resting. while sitting on a sofa, climbing down the hill, not up, down the hill, or something like that, like sitting on a sofa, sitting inside the car, relaxing mode, and there's a chest pain. Always think of unstable angina. And when you go for this biomarker, of course, there will be a clue in the question. You will easily differentiate. So if we check the question here, this question says a 62-year-old man presents with recurrent retrosternal chest pain. Retrosternal chest pain, which he said has become, see, it's a man here. Most of the time, whenever there is retrosternal chest pain and women is mentioned, always our mind goes towards GERD, gastroesophageal reflux disorder. But for men also you will see, but because we have to read the whole question and then we can come to the point, okay, this is GERD or this is, because most of the time when it's mentioned retrosternal chest pain, a woman is there, the first thing coming in our mind is maybe it's a case of gastroesophageal reflux disorder. But here we have to read the whole scenario, which he said has become much worse over the last 3 weeks. He described the pain as lasting much longer than before, and that occurs even while he's sitting in chair or in bed at night reading. So during resting condition, he's experiencing this retrosternal chest pain. Which of the following is most likely type of angina? Here, the question clearly asking you which type of angina. Say, for example, the same scenario, but there's nothing mentioned here angina, and GERD is there. What you're going to do? These are sometimes it's very tricky to answer. Here it's very clear because they are already asking us which type of angina, and if we look for the answer choices, we have to only choose between the choices of the angina. But if the same type of question is there and you have to differentiate between unstable angina and GERD, there must be something in the history also that will pointing you towards GERD. Maybe metallic taste or something, gastroesophageal, you will see some dysphagia, something like that. So always look for the proper history. Maybe this is a broken recall, but because of the answer choices, we can say that, okay, there is nothing much to rule out, because it's a clear case. But always look for the history. History points will always pointing you towards the diagnosis. In these type of questions, which are tricky ones, when you have suspecting 2 or 3 most common like differential diagnosis. So here it's a clear cut, right? It's during resting condition, the patient is having this one. So this is unstable angina. Now this one, a 60-year-old man presents to the emergency department. Now he is presenting here in the emergency department, 60 years old, with heavy retrosternal chest discomfort. The discomfort started 3 days earlier as intermittent brief episodes, which became more frequent and prolonged over the last 24 hours. In the emergency department, he experienced a similar type of discomfort, 5/10 on the pain scale of 1 to 10, which responded well to sublingual nitroglycerin. Serial cardiac enzymes are normal. See, most of the cases, this unstable angina, they are not going to, to be effective when you give nitroglycerin. They do not respond actually. But this patient is actually having so much pain for so much days. Like discomfort started 3 days earlier, and this time the pain is lasting for 24 hours. So this pain is relieved by nitroglycerin. But the next clue is serial cardiac enzymes are normal, trop normal. So trop normal, and initial ECG showed ST segment depression in the anterior chest plate, which later normalized completely. This is again a very, very big clue for us. So initially, if there is any changes, it's okay. But later on, if you see the changes, which is disappeared completely, if it's a case of infarction, myocardial infarction, you can never say that this changes will go on. No, even after some time, you will see in the form of Q waves. But it can never be disappeared. But in this case, the 2 clues are very important. The one is cardiac enzymes, which are normal, and the second one is ECG was showing changes. But of course, after the administration of nitroglycerin, when the patient relaxes, what will happen? What exactly happened in the pathophysiology? Maybe there is a clot, there's a partial occlusion, and later on it will dilate because of the nitroglycerin and the blood flow maintained. And the heart is in the ischemia condition, that's why the heart revives. But if it's in the infarction condition, no. If you give blood to the infarcted heart, it will deteriorate more. That's the very weird thing of infarction. When you give blood, it will deteriorate more.
Excuse me, doctor,
Yeah.
but here is a ST segment depression, not elevation.
Yeah, sometimes infarction presents a depression as well. Yes. There is no, like you will see ST changes. First depression and later on it converted into elevation. That happens sometime also. When there's a start of infarction, but later on when it progresses, you can see a clear ST elevation. So there are two important, so for unstable angina, there will be changes in ECG, later on disappeared completely. You can easily distinguish, okay, it's an
We
unstable
missed the
angina.
ECGs in the reading. Also show the ECGs.
Yeah, there must be an ECG, of course. It's a recall. We don't have ECG with us. Yeah.
In the topics, we missed the ECGs right now.
No, we will cover ECG also later. Yeah, because I am emphasizing only this year recalls. So we will see. Hardly we will see only two ECGs: ventricular tachycardia and one is for pericarditis, which I have received so far. But of course, if we see the later the AV blocks also, and we will cover.
There were ECGs, but we did not do this. Then now again do we after अब कोई आता तभी हम करेंगे साथ साथ, ठीक है?
Okay. All right. For the next one, I think we have to go further. So again, here this is a case of for next one, we have to go for the theory. Okay, abdominal aortic aneurysm will go for 484 page number. Very important topic, abdominal aortic aneurysm. Every time we are seeing recalls on this topic. Here is abdominal aortic aneurysm. So what is the main etiology, the main pathophysiology of this one? The aorta is getting weaker and weaker. Why? Because there is atherosclerosis, there are plaques, there are lipid deposition inside the aorta, which leads to atherosclerosis, and that will lead to weakening of the aorta. And that weakening of the aorta, because of the atherosclerosis, can result in abdominal aortic aneurysm. So we will see aortic diameter expand more than 1.5 normal, involves all layers of vessel wall, and 90% arise from an infrarenal aorta. So that's the type of aorta, infrarenal. We will mostly see this type of abdominal aortic aneurysm in this area. But the most important thing is that aortic diameter expands more than 1.5 normal. So in most of the time, we will not see this one in the clue as a clue. But for the theory purpose, we can say, okay, the diameter is expanded, mostly more than 1.5 and mostly in the infrarenal region. That's why we are saying this abdominal aorta, because of the based on the region, infrarenal. Males are more prone towards female. So in the question, always see the gender of the patient. Age, very important, mostly in the old age, above 60. Hypertension is there, hyperlipidemia is there, of course, increase in blood pressure will be there because of the atherosclerosis. And atherosclerosis, the main reason is increased level of lipids. So we'll see hyperlipidemia. There's a history of smoking in the patient, because smoking is again is an etiology for atherosclerosis. Sign and symptoms, mostly the patients are asymptomatic and may report pulsatile abdominal mass. Sometimes they're asymptomatic, they don't say anything, and sometimes they will say that we are having a mass, abdominal mass which has pulsation. So they can feel themselves as well, these pulsations over this abdominal mass. So the most important clue will be here for us: the age of the gender of the patient, male, age of the patient, history of smoking, history of hypertension, and especially when you do the examination, you will find pulsation over the abdomen. So these are some of the important clues in order to make a diagnosis of abdominal aortic aneurysm. So we will see here diagnosis. We will go for CT MRI. We'll go for ultrasound. The size is very important. Most of the time, the treatment based on the size. So if the size you will see 3 to 4 centimeter, we don't do much. We will just ask for the ultrasound every 2 to 3 years. But if the size of this aorta is 4 to 5.4 centimeter dilated, we ask for CT every 6 to 12 months, like 6 monthly. But if the size is more than or equal to 5.5, we will straight ask for the patient to go for surgical repair, even though the patient doesn't have any symptoms. It's no problem, the patient is don't having symptoms. But what happens if this mass rupture, there will be, of course, instant death of a patient. So we cannot take a risk. We will just say if the dilatation is 5.5 or more than 5.5, you have to go for surgery repair. But if it's like in between 3 to 4 or 4 to 5.4, we can give chance to go for every 2 to 3 years ultrasound or maybe 6 months. So now we see the scenario of this one. Here, a 60-year-old man, so 60-year, age of the patient, gender of the patient, man, presents to the emergency department with epigastric pain. Now, he is having symptoms here. He is having epigastric pain radiating to the back. That is again also very important finding, which is not mentioned here, but if we can check in the main MTB, maybe you can find there. Yeah. Because those are the handouts, maybe they can miss this. Now the venous screening. Okay, there is no much, but the presentation is epigastric pain, maybe in, not mentioned here as well. So 65, there will be a smoking history. 5 again. Okay, here also not mentioned. But these are the things we have to think for it. Like the presentation again is important here. So they are saying this one, that emergency with epigastric pain radiating to the back. He's a smoker, smoking history is there, and has long-standing diabetes and hypertension. So long-standing hypertension, you can always think of atherosclerosis, hyperlipidemia, abdominal examination. There is a pulsatile supraumbilical mass. So there's a clear-cut evidence of this pulsatile. There's a clear-cut evidence of this one, smoking history, gender, age of the patient, and again epigastric pain radiating to the back. This patient is having symptoms. He's not an asymptomatic. And this again, the last one, pulsatile supra, this is the biggest clue for us. Which of the following is the most likely? We'll go for aortic aneurysm. This straight away question, it's not asking for any surgery or something, but maybe there's a question which says like the size is 5.5, which is the recall, not this here, but if you solve the previous recall, you will see especially the centimeters, reading in centimeters. So you have to choose surgery. Always there's an option of surgery, and this 5.5 or more than 5.5 centimeter dilated. Okay. So for the next one, we have to do the next topic first. Now we have core pulmonale. Core pulmonale we can find in ambus. It's not very much in detail in MTB. So maybe I have to show you here ambus. Okay. I hope you can see my ambus screen. So this core pulmonale is altered, structured hypertrophy, dilatation, and impaired function of the right ventricle. So mostly whenever something wrong in the right ventricle, and most of the time reason is because of pulmonary hypertension resulting from a primary disorder of the respiratory or pulmonary artery system. So there may be two reasons, only two reasons for core pulmonale. Maybe there is some respiratory dysfunction and mostly COPDs. So the patients who are having COPD, they can lead to pulmonary hypertension, and that pulmonary hypertension can lead to core pulmonale. Or there may be a pulmonary artery system problem, that is simple pulmonary hypertension. So if the patient is having pulmonary hypertension, that can lead to core pulmonale. So always, if for core pulmonale, remember two things. That the one thing which is very obvious, that there is a dysfunctioning in the right ventricle. Only in the right ventricle. Always think of only in the right ventricle there is dysfunctioning. And why there is dysfunctioning in the right ventricle? Because of pulmonary hypertension. And why there is pulmonary hypertension? Maybe the cause is COPD, or maybe the cause is itself pulmonary hypertension. So maybe this is respiratory COPD problem, or maybe this is pulmonary artery system problem, where there is the pressure increase inside the pulmonary arteries. That will lead to dysfunctioning of the right ventricle, and that dysfunctioning we usually call as core pulmonale. So we have chronic core pulmonale, which is most common form, and it's slowly progressive. Anything which goes beyond 2 weeks, we say it's chronic, and anything which is happening between 2 weeks, we can say it's acute thing. So acute definition is within 2 weeks, chronic more than 2 weeks. Now, acute co-pulmonary sudden overload of the right ventricle, usually caused by acute pulmonary embolism and life-threatening condition. So it's a life-threatening condition, of course. So if we just go for the epidemiology, go for the etiology. So here the etiology, co-pulmonary, two things: acute form, mainly because of the massive pulmonary embolism, because that's the acute episode, and chronic, like COPD. COPD is the most important thing. But there are certain other respiratory problems also, right? Say, for example, the patient is having chronic sleep apnea, the patient is having bronchiectasis, patient is having idiopathic pulmonary arterial hypertension, or maybe a case of typhoid scoliosis. These are all the other things that can also lead to chronic form. But the first and foremost, which you have to remember for your exam point of view and MCQ point of view as well, that is COPD. COPD, and second is massive pulmonary embolism. So whenever there is massive pulmonary embolism, the presentation will be acute. Whenever there is COPD, of course, bronchiectasis, typhoid scoliosis, that are all chronic form. So if we go for the clinical features, so most of the time, the clinical features for co-pulmonary is just like the features of acute pulmonary embolism. So let me show you this one, if I can find here. Not matching here, but we will see the co-pulmonary feature just like pulmonary embolism features. So mostly wherever the features of COPD, wherever the features of obstructive sleep apnea or thromboembolic features are especially shortness of breath, difficulty in breathing, chest pain, cyanosis. These are all the features of this COPD, obstructive sleep apnea, and thromboembolism. And you can see the same features in this patient. So nothing different. For diagnostic point of view, so for diagnostic evaluation of co-pulmonary, it's inseparable from this pulmonary hypertension, because they are actually covering two topics together: pulmonary hypertension also and co-pulmonary, because the presentation is almost similar, but that is only happening inside the right ventricle. But in case of pulmonary hypertension, there are many things which can go simultaneously. So testing aim at confirming pulmonary hypertension without co-pulmonary and determining its severity and underlying. So we can go for Doppler echocardiography. That is the best initial test. Always remember the best initial test, Doppler echocardiography. You can see hypertrophy of the right heart ventricle. You can see the dilatation of the coronary sinus. You can see estimation of pulmonary artery pressure. So if the pulmonary artery pressure is raised, the right ventricle is dilated, you can confirm the diagnosis. So just remember best initial test is this one. Chest X-ray, if you go for chest X-ray, this is not the best initial or the most accurate one, but you can always see the right ventricular, right heart hypertrophy here in the chest X-ray. So for the treatment point of view, we have to go for general measures. Say, for example, if the patient is having less oxygen saturation, we can always go for oxygen therapy, asking for the physical exercise. And for the diuretics one, if there is fluid retention due to pulmonary hypertension, we have to remove this fluid, so we can give diuretics in that case. We have to increase the cardiac function. We have to give pulmonary vasodilated therapy, decreases pulmonary vascular resistance, because whenever there is decreased resistance, there will be less pressure. So here the aim is to reduce the pulmonary arterial pressure. For that, what we can do, we can just reduce the pulmonary vascular resistance by giving the vasodilator. So we can give vasodilator like calcium channel blocker here. So if we just go for the recall. So here you can see a 55-year-old man who is heavy smoker is being evaluated for increasing bilateral lower limb swellings. So bilateral lower limb. So whenever there are lower limb swellings, always think of this pulmonary thing, right? Pulmonary problems always our mind goes whenever there is bilateral lower limb edema, and especially of right side. And here is a smoker also. Chest examination confirms resonant lungs with reduced breath sounds and occasional bronchi. The apex beat could not be easily located. No cardiac murmur is heard, but P2 is markedly loud. The JVP is elevated and bilateral pitting edemas. Whenever there is bilateral pitting edema, JVP is raised. Always think of right side heart dysfunction. Always think of this pulmonary hypertension. So which of the following is the most likely cause of the lower limb swelling? Lower limb swelling. So based on the question, based on the answer choices, you can also evaluate easily, or you can exclude the things. So what are the important things here? Especially this lower limb swelling, heavy smoker, resonant lungs, bronchi are there, no cardiac murmur, there is nothing left involvement, GVP is raised. Always think of this right side heart dysfunction. And whenever there is right side heart dysfunction, always think of pulmonary hypertension and copulmonary. So there is clear cut answer here is copulmonary. So we'll go for this. Okay. Any doubt on this one, on this question? Based on the symptoms, we can easily, maybe the answer choices are not exactly the same, but based on the clear symptoms mentioned in the question, we can say it's a copulmonary. Okay. The next one, for the next one, I think we have to go for the theory. Okay, next theory topic is chronic limb ischemia. So chronic limb ischemia or peripheral artery disease means the same thing. We'll go for page number 51. Okay, peripheral artery disease. So peripheral artery disease or chronic limb ischemia, we can say it's a stenosis of peripheral arteries. So stenosis is there. What are the reasons for stenosis? We can see that, but mostly long-standing diabetes. In a case of when the patient's having too much lipid hyperlipidemia, hypertension is there. History of tobacco smoking. They are all the risk factors for this stenosis of peripheral arteries. And whenever there is a stenosis, it can lead to peripheral artery disease. There will be less blood supply to the lung, especially to the lower limb. So we can say this is a chronic limb ischemia, and the chronic limb ischemia can lead to infarction, and we will see there's certain changes in this one. So what is the most likely diagnosis? Patient usually say claudication, pain in calves on exertion, relieved by rest because it's ischemia, it's reversible. Walking up or down hill, severe disease cause loss of. So with the passage of time, when there is low blood supply, you will see there will be no more hair follicles. Shiny, chin will be so shiny and tibia, like there will be no hairs over the tibia. That's important. That's a very common clue in physical examination. During physical examination, if you can see the patient who is having lower limbs very shiny, there is no hair follicle, there is no evidence of sweat glands or sebaceous gland, we can say because they lost because of ischemia, low blood supply to the lower limb. The skin becomes smooth and shiny. So spinal stenosis pain is worse when walking downhill because of leaning back. So there is an important clue here. You can just, because walking up or downhill, peripheral artery disease can also cause, and then spinal stenosis can cause. But spinal stenosis pain is worse when walking down hills, not going up, especially. So that's only a discriminating factor. Say, for example, you can say this walking up or down can also cause because of this peripheral and because of spinal also. But spinal always when walking downhill, because we are actually leaning back because of inertia. Inertia keeps us back. But if the case of spinal stenosis, there will be pain, worsening pain when going down. Okay, so for diagnostic test, we will go for this ankle brachial index. We will say this is the best initial test. Just memorize this one, and this ratio is very important. So if difference between them is more than 10%, like ABF is less than 0.9, it means that disease is present. So say for example, if any question, you can see the ankle brachial index 0.9, less than 0.9. Most of the time they mention 0.8. So just think of this peripheral artery disease. And you will see the very clear-cut history also in your patient. So treatment, you will
Doctor,
give.
please, yes. Sorry, please repeat this point.
Which point, doctor?
The last one, ankle brachial index.
See, mostly because we have to see. The point is the whole blood supply to the lower limb is decreased, right? So you have to compare. You have to compare the blood pressure over the upper limb and blood pressure over the lower limb, right? In order to see, okay, where is the difference? So you have to check the brachial artery and you have to check the ankle artery, blood pressures of these two, and you will find some differences. So if that difference is less than 0.9, it means that yes, the patient's lower limb is getting less blood as compared to upper limb. So it's a clear indication if this ABI, if this ankle brachial index is less than 0.9, and most of the time in question it says 0.8. So you always think it's a peripheral artery disease. It's only a disease related to lower limb because it's a peripheral.
If difference between them is more than 10%,
then there's no peripheral artery disease. You have to rule out other causes. You have to rule out pulmonary causes then. Getting me? So, but especially for the peripheral artery disease, you have to check the brachial index, ankle brachial index. You have to compare the arterial pressure between the upper limbs and the lower limbs in order to say, yeah, okay, this is a peripheral. Otherwise, it's a central one.
Okay.
Yeah. So, most accurate tests. So you have to always, whenever you are doing any topic, you have to memorize the best initial and the most accurate test. So best initial test is ABI and the most accurate test is angiogram. Of course, when you do angiogram, you will see where exactly the cause is, where is the stenosis of that particular artery. You can easily detect. So single most medication is selective.
Excuse me, sorry. In the exam, they are giving questions like this?
Yes, we will solve one recall where it's mentioned API 0. Yeah. But yes, in exam also they are asking most accurate investigation, and they will give you the exact results also. Say, for example, here, mostly in PAT questions, you will see ankle brachial index. Mostly is 0.8, 0.8, 0.85. These two are very common. All you can see. So, So in all major vascular disease, control the following. We have to control the BP. We have to always think of this LDL level should be below 100. If the patient is diabetic, we have to control his sugar. Of course, sugar level should be controlled. So these are all the important things. And single most effective medication, which medication you are going to give to this patient? Letrozole. So just memorize this one. It's only one medication. Of course, we will ask for a smoking cessation. We'll control his or her sugars, and we will give aspirin in order to decrease the thickness of the blood, just to the viscosity of the blood. In order to decrease the viscosity of the blood, we will give the here as aspirin. So if you can see the question here. 55-year-old patient present to the clinic with leg pain. 55, gender is not there, it's okay, leg pain, brought on by walking and relieved by rest. So here are the clues for you. Especially leg pain, walking, and relieved by rest. The patient reports a history of many years of smoking. Smoking is there. Physical examination confirmed loss of hair over the lower chin. It's a very clear-cut question. Lower chins, no hairs. Why no hairs? Because there is prolonged standing ischemia because of the low blood supply. All the hair follicles, all the sweat glands, all the sebaceous gland gone. As well as dystrophic nails. Dystrophic nails of what? It should be dystrophic nails of feet. And ankle brachial index is 0.8. It's a very, very clear question pointing you towards that you have to choose PAT disease. If there is any PAT disease written, or chronic lymphedemia, it's another name of that one. We'll go for chronic lymphedemia. Then a 55-year-old diabetic, 55, diabetic, hypertensive patient present with a history of bilateral, both of the legs, intermittent leg pain.
Yes. Also read the other options.
Other options you can see. This is a clear case because this is the recall. So we cannot, you cannot rely on the other options because I have mentioned myself. But you can easily rule out. Say for example, if it's a lumbar disc prolapse. Say for example. So how you are going to relate this to lumbar disc prolapse? There will be
leg pain.
See, it's showing leg pain. If it's a lumbar, it's a sharp, excruciating spinal pain. So you can easily differentiate. You can easily exclude this is not a case. Deep vein thrombosis. If it's a deep vein thrombosis, what will happen?
There will be pain, swelling.
Swelling will be there, exactly. And if it's a chronic venous insufficiency, you will see lots of varicosities. There must be something in the physical examination. If they want us to answer this chronic venous insufficiency, there must be some more physical findings there. Not these findings which are pointing to towards.
Findings like?
Yeah. Yes. Now this question,
no, 55. Which findings will be there?
Sorry, doctor, come again.
In the chronic venous insufficiency, what findings will be there?
See, chronic venous insufficiency, there will be too much varicosity. There will be too much drainage from deep veins to the superficial veins because most of the time because of the contraction of the muscles and improper blood supply, especially to the venous areas, you will always see varicose veins. So there will be tortuous veins, something like that. In the question must say some varicosities or varicose veins.
The option A.
Option lumbar disc prolapse, there will be cruciating spinal pain like sciatica. There must be something pain, radiating pain, yes, down over the body. Yes.
Not lived by sitting.
Yes, yes, of course. Not relieved by, yes, of course. Now, a 55-year-old diabetic hypertensive patient present with a history of bilateral intermittent leg pain brought on by walking for 300 meters and relieved by rest. So, diabetic, hypertensive, bilateral intermittent pain, and again relieving after resting. What is the most likely diagnosis? So now you rule out the other choices. Why not varicose vein? Why not diabetic foot infection? If there is a diabetic foot infection, you cannot even go for the walking for 300 meters because they don't have feelings over the field. They are not allowed to walk or run, especially diabetic foot. Peripheral neuropathy, that can be a case, peripheral neuropathy long standing, but in peripheral neuropathy mostly numbness is the feature, not this pain and the pain gone during the after relaxation. So it's a peripheral arteriosus. Okay. So for the next one, we have to go for the theory first. We have this APTA, antiphospholipid. Yes, doctor, you're saying something? 178. Okay. So can I just mute you for a while and you can unmute yourself later? Okay. So we have the next one, Antiphospholipid Syndrome. The most commonly we say this is Apler syndrome, Antiphospholipid Syndrome. So there are two actually things in Antiphospholipid Syndrome. One is lupus anticoagulant and another one is anticardial antibody. These two together named as Antiphospholipid Syndrome. Both causes thrombosis. In both of them we will see thrombosis. Anticardial antibodies associated with multiple spontaneous abortions. So whenever they want us to choose Apler syndrome, there must be a case where the woman is there, she's having multiple abortion history, she's not conceiving at all, she wants to conceive, but during during the first trimester she experienced this abortion. Always think of this Apler syndrome. So antiphospholipid syndrome specifically causes thrombophilia with abnormal APTT, and when you go for this mixing studies, when you go for this blood profile studies, you will see there will be thrombophilia, there will be APTT, and that's abnormally increased APTT. So if we go for the best initial test, we will see this mixing study. We will want to see the APTT and PTT levels. Because it's a circulating inhibitor, APTT remains elevated after mixing. So even though if you're going to mix the blood of this patient with the normal blood, again, you're not going to see any changes in that one. APTT remains the same. Most accurate test for lupus anticoagulant is Russell Viper-Weenham test. That's important. You're just going to learn by heart and treat with heparin and warfarin as you would any cause of DVT. So we will just do the treatment like DVT or pulmonary embolism, and Apler syndrome may require lifelong anticoagulation because it's a case of thrombosis. So treatment. See, this question, this topic is not asked. Always remember, there are some topics which pointing you towards to make a diagnosis based on symptoms. Because treatment is almost usually the same for the others. Say, for example, this Apler, this DVT, this pulmonary embolism, they all have almost the same treatment. So treatment here doesn't matter. The important thing, you can easily extract the diagnosis based on the physical symptoms, based on the clinical features presenting in the patient. So say, for example, here, if they want us to answer Apler syndrome, they don't want us to answer DVT or PE, they will always give you something in the history, in the clinical features or etiology that will pointing you towards to choose Apler syndrome. Say, for example, there will be a case of women showing your multiple abortion history, APTT is raised. Think of this Apler syndrome. So the recall is based on this one. So the recall here is a 35-year-old woman presents with bilateral deep vein thrombosis. She has a history of recurrent stillbirths. So they're pointing you towards this one, and result value is APTT 55. It's raised. Which of the following is the most likely diagnosis? So you will see this antiphospholipid syndrome, antithrombin deficiency, protein S, protein C. So protein S, protein C, you cannot say like that. You have to go for the examination. You have to go for the testing. Then only you can say. Based on the symptoms, you cannot choose these syndromes. But based on the symptom, you can choose this syndrome. Definitely. So
why not antithrombin deficiency, doctor?
now antithrombin deficiency, again, how you will say? You have to measure thrombin levels and then only you can say. So it's simple, na? Because see, some diagnoses are especially based on lab test result. You cannot say the clear diagnosis before having test in front of you, right? But some other diagnoses where just only based on the symptoms you can say that this is this one. So Epler syndrome, only on the basis of history you can say, but of course when you go for the antibody testing you will find antibodies there. But for this antithrombin protein as protein C, they are totally dependent on lab values. You cannot predict them before having labs in front of you. You cannot say that. You will say some thrombotic disease, but you cannot say it's a protein as a protein C deficiency unless you have a result in front of you. You're getting me? So for next one, we have to go for the theory first. Peripartum cardiomyopathy, very, very important topic for MCQ point of view. Page number 53. Okay. So peripartum cardiomyopathy. So it can be just started after delivery and maybe up to 6 weeks of delivery you can see in this case, because the peripartum time period after delivery till 6 weeks of delivery. So unknown why antibodies are made against the myocardium in some pregnant women. So antibodies started making before even delivery of a patient. So during pregnancy, these antibodies are formed against the myocardium, against the heart, especially in pregnancy. There will be left ventricular dysfunction, often reversible and short term. If left ventricular dysfunction does not improve, then must undergo cardiac transplantation. That is the very hilarious point, right? But very dangerous thing. But usually what happens that there is LV dysfunction, but it's reversible one. Because pregnancy is of course, it's time bounded, right? It should be 9 months. So this time period, the patient can survive. But after that, if there is no improvement in the left ventricular dysfunction, we have to go for the transplantation. So they are the same as for dilated cardiomyopathy. We have to give all these drugs which can reduce the mortality of our patient. Nothing significant, all are for the mortality, decrease the mortality, and repeat pregnancy with peripartum cardiomyopathy will kill 50 to 70. That's why we always encourage our patients, we always counsel our patients not to pregnant again if they have this peripartum cardiomyopathy. So what is the most important thing? You are going to see antibodies in your patient. You are going to see, you are going to give a treatment just like for dilated cardiomyopathy. There is nothing much different. But peripartum cardiomyopathy develops after delivery in most cases. Just memorize this point that soon after delivery, if the patient is having symptoms of dilated cardiomyopathy, if the patient having symptoms of left ventricular dysfunction, always consider peripartum cardiomyopathy, and always you have to give ACIs, ARBs, because they are actually going to reduce the mortality of your patient long term. So if we can see the question here. A 29-year woman presents to the emergency department complaining of being unable to sleep flat for the last 2 nights due to difficulty in breathing. So difficulty in breathing, the very important clue symptom here, she has just delivered 1 week earlier. Physical examination confirms a laterally displaced apex beat and the presence of third heart sound. Whenever there is a third heart sound, always think of this left ventricular dysfunction. The jugular veins were distended and bilateral lung crackles could be easily heard. So which of the following is the most likely diagnosis? Again, you can see difficulty in breathing. This bilateral lung crackles can be easily, and distended jugular veins, again pointing you towards with this difficulty in breathing, because something related to pulmonary system is there. There is no clear-cut evidence of pulmonary embolism because she's not presenting with acute shortness of breath. She's just presenting because for being unable to sleep flat for the last 2 nights. See, you have to make a clear-cut difference whether it's a case of pulmonary embolism or whether it's a case of peripartum cardiomyopathy. Because if the presentation says acute shortness of breath, then the case is different. But here it's saying complaining of being unable to sleep flat. There is not too much difficulty in breathing. There is, but only when she is lying flat, or the time period is for the last 2 nights. And she has just delivered, so you can think of this. So which of the following is the most likely diagnosis based on her delivery status, based on her difficulty in breathing, which is not very acute, based on her pulmonary findings as well. We can say that which of the following is the most likely diagnosis. We can just rule out peripartum cardiomyopathy, pulmonary embolism. For pulmonary embolism, there should be acute shortness of breath, which is not a case here.
Yes.
Myocardial infarction, you cannot say myocardial
Yes,
infarction
yes.
like that, right? And there should be, it cannot be like that, something you sleep flat. And,
Acute is
yeah,
severe pain.
yeah. And pneumonia, of course. So you can just easily say
Doctor,
this.
why the apex beat is displaced?
Because of this pulmonary findings. See, distended lungs. So distended
Sorry?
lungs, distended lungs, huh? See, there's distension in the lungs. Lung trappers, fluid is there.
No, why the apex beat will be displaced?
Yeah, see, the mostly the findings in the apex beat you are always find displays whenever there is pulmonary involvement. So if there is distension in the pulmonary system, which is of course for a shorter time period or it's reversible one, you can find apex beat displays, but it's just a temporary finding. After some time, when she's relaxed or in upright position, you cannot see the same finding. But during lying down position, you can see it's a displaced thing, because overall, because of the pulmonary, you can say pulmonary filling, not pulmonary embolism. You cannot say the word like that. Yeah.
Apex
Yeah.
beat is displaced always due to pulmonary reason, huh?
Yes, always pulmonary. But here, it's not an irreversible thing. Nah? It's not embolism, especially. It's just
Yeah, yeah.
pulmonary retention, you can say, because
Yes.
of the lying of the posture, because of the dysfunctioning, or because here the myocardium is involved. So distension of the heart, you will see that myocardium distend. Of course, the apex beat will be distended, will be displaced.
Yeah, it's finding us similar to congestive heart failure.
Yeah, dilated cardiomyopathy, dilated. Everything in peripartum cardiomyopathy relates to dilated cardiomyopathy. So just think of this one. Dilated heart, apex beat will also be displaced.
Yes.
So that's all for today.
Talia.
Don't have yeah, much here. So what we are going to do, I will just share the another. See, my point here is not to make your theory or concepts clear. My point here is how to solve actually recalls based on the knowledge which you have on your topic. So what you can do, just go over the theory again and again, because you cannot rely completely on MTB. Something you will find in MTB, something you will find in numbers, some you can find in even I cannot find this co-pulmonary very well in Toronto and very well in Kaplan. So just go over the theory from MTB. Of course, first read, you will not, most of us, like if we are having a background from gynae, we don't have much to do with internal medicine. So we are really finding it difficult, but we will do if we can just go over the theory again and again. And I will highly recommend you, if you have videos of this MTB step to CK by Dr. Conrad Fisher, go over that. It will make your concept a lot more clear, starting from the basic to very advanced level. But
Are they
anyhow,
available on YouTube? Are they available on YouTube?
Yes. On YouTube you can find, yeah, lots of there. Or on Telegram, if you can find on Telegram.
They were available, but now they are not available.
Just try and find it. If not, then I will help you in that one. So let me just stop the recording first.
Yes, yeah, doctor, you have sent this MTB notes. These are the same, the MTB book, and these are same. These are same.
One minute, doctor.